share from our successes and our failures. And that's why we have a number of communities of practice, which goes across different sectors so that people from different jurisdictions and different PHNs and different areas can say, oh, I was doing this, and so that you can really learn. And if people made a fair bit of progress and someone's saying, oh, I think I might do this initiative, someone say, yeah, well, I've done that already, so why don't I share where I've got to? And this is a great thing about, I think, the area we work in. There's no proprietary about this. We all want to share, we all want to encourage one another because we all share the same agenda, the same goal of improving the physical health of people living with mental illness. So this morning is a little bit about converting this policy imperative or this national imperative and the policy of Equally Well and the policies across the states into action, because that's where there's so much slippage. There's lots of, the road to health is paved with good intentions, and there's lots of great intention, there's lots of great work happening, but sometimes converting that imperative into changes in practice and changes in people's lives, we struggle at that. That's something that we really don't do well. You know why? Because we're mostly mental health trained consultants, advocates, clinicians. We're not implementation scientists. So this morning we have, I think, a great panel of people who I believe, hand-chosen by Professor Roberts, who I believe has actually made a massive impact and have got a track record of doing just this. And I've got to say, there's a lot of policies, as you know, that are on the shelves where nothing's happened. In this case, for these four speakers, you can see tangible outcomes from what they've done. So just a brief introduction. We've got Carolyn White, who's working with Mind, which is an NGO, and also an Equally Well ambassador. Next to her, we have Trish O'Riordan, who's the Senior Policy Officer, probably a director. You keep going, get promoted every time I turn around, Trish. From New South Wales Health, who's been leading a lot of the work around the New South Wales Health policy about improving the physical health of people with mental illness. We have Ruth Vine from the National Mental Health Commission, but also comes with, Ruth, decades of experience across many, many different settings of successful and impactful work. And Kat Goodwin from the Assessment, Central Eastern Sydney PHN, and really the work that the PHN is doing is fantastic. So what we're trying to do this morning is people from very different contexts, from the NGO, from state government, from national government and PHN. And what we want to do is try and learn and glean from them some of the lessons that they've learned about turning the policy imperative or the policy intention into changes of practice and changes of outcomes for people. So what we're going to do is have about 2 or 3 minutes each where they're going to give some of the key first reflections on this, and then a bit of a panel work, and then we're going to provide a bit of time for maybe 15 minutes for question and answers for the panel at the end. So with no further ado, let's get started. So we'll just, I'm not very creative, we'll start with the person closest. So Carolyn, could you just give for 3 minutes a bit of a summary of your key insights about converting policy into practice?
For that, Russell. So I'm Carolyn White. I'm the Participation and Co-Design Manager at Mind Australia, and this is a designated lived experience role. So to this role I bring family and carer lived experience. So when it comes to physical health and promoting the physical health of people with mental ill health, that's a very personal issue to me because I've supported family members who are navigating various mental health and physical health systems, and I can see what happens when things go wrong. And so that's what drives a lot of the work that I do. So I think I was thinking about this converting policy to practice from a kind of journalistic kind of mindset. So, so the who, what, how, when and where kind of questions. So in my work, I often think about who's most affected by the issue that the policy relates to and who was involved in creating the policy in the first place. So were people with lived and living experience involved in the policy conversations and coming up with the policy solutions? And whose voices were missing? So that's a really important question because you can't apply something to a population without kind of tailoring it to the needs of that particular group of people in the context where they live. So thinking about the what as well, so it's kind of thinking beyond kind of behaviour and lifestyle. So individual people can certainly take action to support their health and well-being, but if we want to make a real change in terms of promoting physical health, we need to be addressing the social determinants of health. So thinking about kind of, we talked yesterday about things like poverty, things like racism, things like food insecurity are all really key issues that we can't ignore. So when it comes to the what, we can maximise our return on investment by doing both. So supporting individuals, but also addressing some of those social determinants. So a couple of examples of how we've done that is like when we're organising catering, for example, for a group program, then getting a social enterprise to do that catering for us so that the money that we're spending is not only benefiting the participants, but it's benefiting the people in that social enterprise. So it might be people with disability, or it might be a Indigenous-led organisation. Or it might be kind of engaging peer workers so that we're providing employment opportunities as well as interventions to support individuals with their physical health. So in terms of the how, we really need to listen to lived experience and also practitioner wisdom. So Felice mentioned before that a focus on body weight can contribute to stigma, and that's something that I've done a lot of work in. And it also focuses on something that's really difficult to change. But policies still kind of recommend BMI measurement and waist circumference and things like that. So at the two kind of equally well symposiums that we've had previously, Caro Swanson from New Zealand, made comment around how regular girth measurement does nothing for her mental health. So we need to be thinking about how we do that. So yesterday we spoke about human rights, and one of the things that came up is the right to body autonomy. So thinking about kind of, okay, so if we have to do waist circumference and BMI, then thinking about asking the person for their consent to do those and making sure that they're informed about why we're doing that. Providing a private space to do that, and also asking the person whether they want to know the numbers or not. Because for people with an eating disorder, that can send them into a spiral that is not helpful for their recovery. And we might also kind of provide options for people. So as well as the standard kind of recommendations, thinking about kind of size inclusive advice that focuses more on the activities and behaviours that people can do within the context of their lives. We talked yesterday in my session about kind of when to introduce these kind of conversations. So what we've learned from our lived experience advisory team is that it's not the first conversation that you have with a person. You need to have built some rapport with the person and have a trusting relationship before you start conversations about physical health. We need to recognise that people might have other priorities. So they might be worried about kind of where they're going to sleep that night, or if they're going to have enough money to put food on the table. So thinking about kind of what their priorities are, and then if they don't want to address things now, then thinking about kind of revisiting that conversation later down the track. And if a person doesn't want to kind of act specifically on their physical health, then think about what can we do more broadly to create an environment that supports people to do things that support their physical health. So for example, at one of our prevention and recovery care centres, I visited one day and they had bikes there, which is fantastic, but the tyres were flat, so they couldn't be used. So making sure that what we provide is able to be used. So in terms of kind of where, start with the places that you can touch. So it's a big issue. We can't do everything. So start in, your own environment. And as Russell says, kind of do what you can, where you can, and when you can. Thank you.
Fantastic. Thanks, Caroline. No, Jackson from community development talks about you have to start at point of felt need. You don't go on what you want, you have to go on, so what does the person that you're working with, where is their need and where do they want to go? So thank you. Trish, one of the lessons for me as a sort of a professor in leadership is about the importance of endurance and building a reputation and a perseverance and in the sector, and that only comes with time. And I don't know how long, but at least 20 years you've been working, establishing a magnificent reputation and for delivering and being a great conduit. So I'm really interested in, and I think that's been evident in the fantastic work that's happening in New South Wales at the moment. So really interested in some of your reflections on how you've been successful.
Thanks, Russell, and thanks for the invite to talk here today, because it did give me the opportunity to reflect a little bit on the way we went about implementing the New South Wales Health Guidelines, but also I think on policy more broadly, how we go about implementing it, how we make sense of it so that when it lands on the ground, it's something that's meaningful, doable, and something that locally is owned and accepted. There are a few things I think when I went through that I learned from particularly the implementation of the physical healthcare guidelines, because there are many doors that our clients have to walk through in order to get the kind of care that they need in this space. The first thing I learned, and I think I'm echoing a little bit of what you say, so my apologies, but that listening is invaluable. We can't design, write, do anything without hearing from the people, and we heard the Minister even talk to that this morning, the bravery it takes to tell your story. And it's not enough to just acknowledge it, we need to act on it. So listening is invaluable, and it makes us all the more richer when we're able to put into practice things that people have told us does not work. Well, we won't put that into practice, right? I got that wrong, but we put into practice the things that will work for people. And so going forward, I think for our policy, our guidelines will be coming up for review soon. One of the things we'll be holding very dear will be the need to kind of make sure that anything we write is informed by the people for whom we are serving. The other thing I would add to that, though, is that we need to be honest and keep people informed. So one of the big lessons for me from working through not just this set of guidelines, but other ones, was the realization that I wasn't always upfront with people when I was bringing them on board to design or co-produce a policy or an implementation guideline. So you have to be able to be upfront with people from the very beginning and know what you're asking of them, explain why that is, and keep them informed along the way. Some decisions will be made before you even set foot in the room, and acknowledging those and telling people what they are is a powerful way to take it forward. And that might be for legal reasons, it might be ministerial reasons, it might be funding and resource. It's not to be exclusive, but it's just about being clear. Are you co-producing? Are you consulting? Are you co-designing? What is the aim of bringing people on board and hearing their stories? I think it was one of the learnings for me was learning to be, and it sounds kind of very simplistic to say this, but learning to be flexible when somebody came up with a much better idea than the one I thought I had. It's really important, right? We just have to let go of stuff sometimes and go, you know what, that is a better way of doing things, and therefore I should. The other lesson that came out from it, particular to the physical healthcare guidelines, is that partnerships are pivotal, and we need to use the power of partnerships if we really are to make change. I think for me, in mental health, a lot of ownership fell to mental health services to deliver on the product that we put out there. When in fact we know, when you're looking at complex chronic illnesses, when you're looking at people who may be diagnosed with oral cancer or other types of cancers, you need more than a mental health service to deliver. So not just looking for one solution, but really knowing that there's power in leveraging off the partnerships and really using them to their maximum benefit. And then I think the last thing that was a bit of a learning for me was that one size won't fit all. And I learned that a little bit from the work that Jackie and the Commission showed us earlier this morning. You can often design a policy and it can be very, straight, up and down, narrow in its remit. But that's not the real world. People's lives are very different. People come from different cultures, different backgrounds, different groups, and therefore they will have different needs. So our policies need to be more adaptable, they need to be more flexible, and we need to acknowledge that one size won't fit all. They were probably my key reflections, Russell.
No, that's great, Trish. And I know we talk a lot about the partnership and lived experience, experts by experience. And as with my rural hat, we talk about place-based expertise as well. And that's what you're talking about. What might work in inner metro Sydney might not work at the back of Dubbo or Burke or something. So once again, partnering with those who have the place-based expertise is actually critical. So thanks for highlighting that. Ruth, from your varied perspectives.
Thank you, and I'm going to try very hard not to repeat what we've heard already, which of course I absolutely agree with. But I guess when I'm sort of thinking about how you put policy into practice, there are some key things that can be both enablers and blockers. And those key things, I think, are people, dollars, and systems. And I thought maybe I'd give a couple of examples. The first one I'm going to give is from way back when I was working in clinical mental health services. We had the opportunity, we had a little bit of extra money, and we employed an enrolled nurse to proactively engage with our local public dentist to make available a couple of sessions a week for our patient cohort. Now, some of those people had actually never seen a dentist, which is appalling, but I'll give a call out right now that I think dental health is absolutely critical as part of our physical and mental health. And so anyway, it worked. We had an engaged dentist. We had a specific resource through this enrolled nurse who really got on well with our clients, our folk, and assertively assisted them to get there, and they were, that it worked. But in order for that to work and keep working, we'd actually needed to keep having the resource. We needed to keep having the relationship with the public dentist, and a willingness on their part to give us really prominent access to the chair, and we needed the systems and recording in place. So that's just a little example. The other example I thought I'd give, which is a much broader one and may link to PHN work too, there is an overarching policy of this government around equity of access and probably equity of outcomes. And we know that that's really hard to achieve. And one of the things that we learnt when we were doing an evaluation of better access was that there was not equity. There was not equity of access. There were differential workforce things. There were differential affordability aspects, and there were very different outcomes as well. And two responses to that, which I think are really important to note, and we need to watch. One was to continue with the establishment of a free access, multidisciplinary model of care, which is just unfolding. And I have to say, COVID helped us a lot with that. It was a really great time to experiment. But the Head to Health centres, which we're delivering through the PHNs, promoted part of that. But the other part, which I think is really critical, is that there was also engagement through government and through budget processes to change some of the MBS items to encourage and make more viable bulk billing for particular patient cohorts, for particular presentations. Now, that's the sort of thing that takes a sustained will. It certainly takes dollars, and it absolutely takes an availability of the right workforce, an availability of the right leadership and governance, and indeed a close monitoring of outcomes and value for money. So I think, you mentioned decades, Russell, and it is of course true that it has been decades, but through that decades I have seen some great policies that have been able to be put in practice. But I think sustainability and generalisability, so it's not just in one patch, are just so hard to achieve without really, really strong leadership. And all the things that both Tricia and Carolyn have talked about in terms of partnership and engagement and communication.
Fantastic. What I've heard there is that the importance of having the right people, having the resources, including the money, of course, and the workforce, and also having the relationship, and then the systems, which sort of brings all of those things together. And then that's underpinned by sustainability and feasibility. So, wow, what a great summary. Kat, very different environment, a very new environment, and at Central Eastern Sydney PHN, you guys are doing fantastic work across so many areas, and already I've seen that you're echoing some of the things that Caroline, Trish and Ruth have said about the resources, the dollars, the partnerships and listening. So really interested in the work that you're doing. There's so much new work, and your learnings and your insights from all of the projects you've been doing across assessment.
Thanks, Russell. I thought I'd talk a little bit about what we're doing and what are some potential next steps in this space. So primary health networks are funded to improve access and the quality of primary care services, and in particular for people who typically miss out, so more vulnerable members of communities or communities that are hardly reached by primary health care like GPs and allied health professionals. So within In addressing the physical health of people who live with mental illness in this space, one of our main levers for moving policy into practice is our commissioning of mental health services. So within our funding parameters, we've been able to do this in a variety of ways. At the very start of the process, when we tender for services and we put out our specifications, we will ask providers, how will this service meet the physical health and wellbeing needs of people in the program? It may not be the core purpose of the program, but we ask that, and it's one of the key selection criteria for procuring providers. And then once we have services up and running, they've gone through co-design, they're based on evidence-based practice, and we will ensure that they adhere to the latest guidelines. So in particular, the New South Wales Health Guidelines for physical health for people living with mental illness is a key one. And we'll ensure that it has tools and resources built in. One that we roll out across our programs is the NEMI National Health Prompt to make sure there is that routine assessment. We also really do focus on funding integrated models of care, so ones that get general practice and hospitals working together, that interface of primary and tertiary services working together. An example of this is the GP shared care programs that our local health district partners run. We support funding and partnership to that. So that sees GPs working in a collaborative relationship with community mental health teams as part of the overall support around a person. And we also do quite a bit of workforce development, so education, quality improvement initiatives, guidelines, and we partner with experts in the sector to do that. In terms of where to next, there is opportunity for PHNs to amplify what we do in this space, and in particular, I think outcome measurement is the opportunity. So at this point in time, to look and see if a program is successful, that's based off improvement in mental health, outputs of service delivery, people, client and patient consumer rated measures of what they think of the program and didn't benefit them. But I think we could move to outcome measurements around addressing physical health and wellbeing, and I think that could really shift practice in this space. We're very interested in funding more integrated models of care like Head to Health, where people can come and have their health, their social, their physical health, their mental health needs all met in the one place in a really seamless and accessible way. So we're interested in building upon those models of care. And we're interested in coming together as PHNs. So you mentioned scalability and generalisability. We are funded for local solutions, but we recognise that coming together and rolling out broader approaches is of benefit. So in New South Wales, the PHNs are coming together and we're reviewing what we're doing in this space and looking for areas where we can work together to increase what we can do. So that's actively underway right now.
Great. You know, we're all friends here, and I think it's great to talk about the principles, but sometimes the best learning, which we really focus on in Equally Well Communities of Practice, is what are the landmines that you need to avoid? Because you step on a landmine, that can completely disrail a program. There's 12 months down the tube, or damage a lot of the people who are not going to come back and participate. So I know for myself, one of my early learnings as a mental health director out western New South Wales, turning up to a regional assembly at Burke and getting smashed by the local working party, and then getting some advice from some of our Aboriginal folks like, you need us sitting on the side. So then I went to the next one, and I'm endorsed by the community. I've got 2 Aboriginal women sitting next to me, and it was a much better experience, I've got to say, because it's getting the endorsement of the people with credibility, rather than me, a white bread blow-in, who's new to the community, only as a director 1 year in. These are people who have been in the community for so there's gives you some credibility by association. So for me, I really learnt the importance of getting alongside the local experts and authorities and respected people and getting them alongside and being clear that this is a partnership. So that was one of the landmines I stepped on, and I was young enough and stupid enough to be resilient and come back into it again. But that was one of my lessons. I'd be interested from the panel of any of the missteps that you think might be helpful to share for all of that, the rest of us who are still looking to implement policies. Any war stories, battle stories?
I'll go first. I think that's really interesting. When we were doing the physical health care guidelines, smoking cessation was a big area. And I would say that I very quickly attached myself to Jackie and her team because that gave me credibility. Nonetheless, smoking was a big issue for us, and we weren't having much success in reducing smoking rates, particularly for people who came into our care smoking and how we managed it. So I decided I'd get on the phone one day and talk directly to our colleagues, whom I hoped were our colleagues. They still are now, but there was a rough patch there, and talk about, really I think I went in with the approach I was demanding. I was demanding that they stood up to their, service delivery. I was demanding that they did more for us. I was pointing out to them. They raised the point with me that there was some anxiety, and I think we would all be familiar with this, around going into a mental health inpatient unit. That discrimination kind of came forward. And my rejoinder back to them was, so you're telling me you have people that work for you who can support 1 in 5 of the population. And it was a shutdown. That's the truth. It was just a complete clam up on their part. I came away thinking, I don't feel good about that. I didn't achieve anything. And I had to really roll my way back in very slowly. And actually, what I did was I put some other people forward and let them kind of mellow the feels and go, yeah, she can be a bit cranky, she can get a bit off, we'll manage her. But it was a good lesson. It was a good lesson, right? Because I needed them. Same way when we do policy, we can write the best policy and the best words ever. But unless we have people like you out there who can do it and who are willing to come along and do it, implement it, they're just words on paper. So you do have to take that step into the real world and be a bit real and, I suppose, be a bit kind of flexible and adaptive, give and take, rather than what I did, which was demand, insist, and just point out the flaws.
Great, thanks, Trish. Any others? Ruth?
I just, maybe to add to that, I think what your reflection, Russell, was know who you need to engage with before you take the steps. And I think that, Trish, you're saying that too. And I guess in the course of my career, I have at times felt that, right was on my side without necessarily thinking that other people don't have the same view and that there are industrial implications. And if you try and do things without engaging industrially when you're working with workforce, and particularly when you're working with a workforce under pressure, if you don't have your rationale right and you don't have your engagement right, you will fail because that will just block. And I certainly experienced that. And the other thing I'd say is sometimes you can be very opportunistic. And again, a recent example, 2 recent examples of that for me. One was during COVID when we had the opportunity in Victoria to do the pop-up, what were then called Head to Help clinics. It was opportunistic. We could get money. We could get the people. We had the PHNs. We had a great PHN leader in Elizabeth Devaney, who was our Southeast Metropolitan PHN leader then, and we could just do it. So it's sort of being opportunistic as well as thinking who you need. And perhaps another example, again, from my career is working in forensic health. If you don't, and particularly important for physical health and mental health, if you don't engage with the other practitioners who work in a given system, again, it won't work. And again, I'm thinking of working with some fantastic general practitioners who worked in prison settings, under the pump all the time, lots of system barriers, but in the end, we got a really good result in a more cohesive model, but there were blocks along the way.
Kat, you've put in so many different innovations. You must have experiences of things that have gone not as well as some of the other projects.
Probably unsurprisingly, I think when things go wrong, it's when we rush in. So often we might have an underspend or some last minute funding, you need to commit it quickly. It's not the time to innovate, it's not the time to try something new. So we have had instances where, procured some services and maybe they weren't supported and networked enough to work with people who are living with more severe and complex mental illnesses. So things kind of fell apart is one lesson I think about in terms of rushing in. But mostly with good planning and good partnership and good expertise, things can be worked through, I find, yeah.
And Carolyn, did you have any, or you were?
Yeah, I think I've got a couple. So I suppose, I was working in a community health service and doing a project around how to support the community around issues to do with body weight. And at that time, I'd always grown up in a smaller body and I was just like, okay, it's easy. All you need to do is eat well and move more. And it's piece of cake. And so it wasn't until I started talking to the dietitians and like at the time, I think I was reading that Sweet Poison book, which was written by a lawyer and things like that. And they're rolling their eyes, just going, what on earth are you doing? Listen to us. So I think like the lessons in that for me were kind of challenge your own biases and also, you know, consult people who really understand the topic that you're dealing with to fill in the gaps in your understanding. I think that was really key for me. And I think the other thing I was thinking in relation to your comments, Tricia, was it doesn't stop with co-design. So I think one of the challenges that I've been dealing with in my practice is we put a lot of energy and effort into co-designing a new product or an approach or a service, but then it's developed and we've got a product or a service, but then it stops and we move on to the next project. But I think we need to build in time and resourcing into making sure that that product or service is actually fully implemented in the services and training up the staff who are kind of going to be responsible for delivering it and providing that ongoing kind of practice support as well. So a couple of things for me.
Oh, that's a great point. I remember before we even got Equally Well started, Peggy Brown, who was a commissioner then, said to us, well, it's 2 years to get it started, to implement it, and 10 years to get it consolidated. And that was about 7 years ago. It's so true. Like the time it takes, it just does take time. It doesn't stop with the design and the consultation. It starts. That's the beginning of the beginning. 2 years down the track, it's the end of the beginning. So now we've got opportunities for a few questions and for people to share their perceptions for the next 10 or 15 minutes. So I'll just open it up to any questions from the panel from the floor. And we might need a mic runner. Sonia, who's going to run the mic. Can we get this one live? We've got one at the back. Oh, the joy of youth to actually be able to run with a microphone.
Thanks. Thanks for those reflections. I think it's really great to hear those kind of high-level thoughts about, well, what works and what doesn't work. I wondered whether people on the panel had some examples of where they feel like they've had some success in terms of implementation in practice of physical health, practice improvement.
Anyone? I know you all have.
I'm happy to go if you like. So yesterday, Lauren and I presented some of the work that we've been doing at Mind Australia to introduce a physical health tool and to support staff to have conversations with the clients that they work with around physical health. So I think we've seen since the introduction of a co-design tool, we've seen an increase. It's not a substantial increase at this stage, but there has been more conversations had around physical health, and so that's a really great starting point. And now we need to kind of build on that by kind of exploring with people ideas that, to put some of those physical health type approaches into to action to support people to take action in their own life based on what's important to them and the resources that are available to them.
And Trish, I know you've had massive success. I needed to correct Professor Curtis's presentation this morning. She missed out an important part in her timeline. In 2008, she came out to Dubbo and ran a one-day workshop improving the physical health of people with mental illness in Dubbo. So that was part of one. All of the other stuff that Jackie did with local health services for the decades before, she became a world superstar, but really working locally. But also part of that success of what's happened in New South Wales. That was 2008, and that was really when we were just sort of getting going in that. So I'd be really interested in the success that New South Wales have had in the partnership with Keeping Body in Mind and also through the LHDs.
Yeah, no, that's a fair point. I don't think I would say they're my successes, because they're not. But it was surrounding myself with the right people, or being surrounded by the right people. So much of the work that happens in New South Wales happens in pockets of great practice from very committed people who are there to make a change. So I could call out a few things like where they've had success with smoking cessation, which I mentioned earlier, with getting gym equipment into places so people could exercise easier and quicker. We've done some work over at Macquarie around improving food and the quality of food, all at the lens of, improving physical health care. But really it is about the people and the power that's in, what I said earlier, those power in partnerships and using them well, and the power in the people, giving them the go-ahead to go and fly. So they wouldn't be my successes, they really would be successes that have landed in services, yeah.
And I think it's also appropriate now, again, to acknowledge David Pearce, who in fact gave one of the keynotes in November 2015 when we were developing the consensus statement, when we had the consensus workshop. And he was the director of New South Wales Mental Health for a long period of time. And really, that's when we talk about authorising environment, we talk about place-based expertise, but we also talk about the executives. We also talk about lived experience. We also talk about research. So it's really acknowledgement to David and his leadership.
Look, it is really hard, isn't it, to think about successes that have been sustained and measurable. I mean, I think the whole, the policy, if you like, of not having smoking in lots of areas was really, really hard to implement, particularly, I think, in mental health units and often quite fraught. But nonetheless, that persistence and that engagement and working with people, I think, got there. I think there is also, the other thing I'd say, Russell, and perhaps, it's a reflection on that equally well has been around for a while and that it is in people's minds that there are different morbidity and mortality outcomes for those with mental illness compared with the general population, that there is a greater recognition of that. And I think that has been reflected in some of the MBS changes that have been introduced in terms of more coordinated care, longer bulk billing sessions, particular availability of different things. But even those, we've still got to measure the outcome. We've still got to measure an outcome over a longer period of time that says it is making a difference. So I think we're doing a lot of good things on a lot of fronts, and I certainly think there's awareness and knowledge, and I'd like to think that some of those policy delivery into practice will make a difference. But I'd still say persistence. We've just got to keep on at it.
No, spot on. I know it's great that we've got a number of GPs here at the conference this year. Kat, this is one of your mandates, is connecting with GPs, and I know you've done some great successful work there. Maybe give an example of one of those GP programs.
I can speak briefly to one that comes to mind, but I believe our friends from South East Sydney Health District are presenting on it this afternoon or tomorrow, so I won't give too much away. But it kind of goes to what you said, Russell, about go to where there's need. And they approached us and said, we have people in our clozapine clinic who really could be supported in primary healthcare by GPs, but GPs aren't trained up in prescribing clozapine and don't have the support to do it. And are you interested in working with us to help us with that? And we were like, yes, we can. So we contributed funding and partnership support to support that service, to link into general practitioners and get people into more sustainable and the right level of care. So that's one example. And all credit to them. The will was there, the interest was there. They just needed some additional resources and linkages, really, to just get it off the ground. Undertook a really fantastic co-design process. So you'll hear more about that later today.
Great point. Yes.
I've just thought of a couple of things. So I think sometimes you don't see the outcomes immediately, you see them down the track. So I don't mean to single Dave out, but a few years ago, quite a few years ago now, we worked together on a project called Framework for Inclusion, which was about kind of supporting people with mental ill health to access the physical health services offered by the community health service. So at the time we employed Dave as a consumer consultant who worked on some resources for staff, and so that was the first time that community health organisation had employed a consumer consultant. And so to see Dave now kind of co-chair of Equally Well, it's a real kind of testament to investing in lived experience and growing that lived experience leadership. So so well done, Dave. I can't take full responsibility for that, but I think I had a part to play in that. And I think some of the projects that we did back then are now being kind of rolled out in other community health services and having a much bigger impact. So, yeah, what you invest now will reap rewards later on.
I think that's a great point in the persistence. And now occasionally I go to the gym and one of the songs I hate is I get down but I get up again. No one's ever going to keep me down. But this is part of the journey for all of us. If you want to be successful, you're going to get knocked down a number of times. But look what happens over almost a decade, that you develop your leadership by the failures and the knocks, etc. And you develop, and you can't do it without that. So that's that persistence that we were talking about as well. We've got a couple of questions here. This one was first and then this one next.
Thank you. I've got a question. I'm a clinician working with a community team that we're quite enthusiastic about trying to do all of this. But there seems to be, at my level, I've never done research before, I can sit and see all of this and do all these amazing things that are happening. But I think, well, I've probably got to get the data on my team and I probably should do a little bit of qualitative and quantitative stuff. And I thought, I don't quite know where to start. Is there somewhere, or is equally well bringing in somewhere that provides some mentorship or some resources or some way to access those of us that are really keen on this but don't know where to start? Because what I keep hearing is there's really good programs, but we should have some research basis or we should be doing some evaluation. Sitting in the community trying to do it is actually hard. So that's my question, is there stuff coming, or how can I access something? How can others in the room access that?
Well, first I'll throw to the panel about the issue of working in community teams to when there's not many resources and there's some enthusiasm, but there's a need for guidance and leadership. Any experiences of how you've dealt with that and working with teams?
So I said earlier I was very fortunate to be surrounded by good people. We have a working group that lead the implementation of the New South Wales guidelines, and part of what they did was they set up a kind of a resource link portal. I'm not so sure if it addresses your specific question around the evidence, because we know the evidence for these programs is there, and we know the evidence around the poor outcomes for people with mental illness is well established, so we don't need to repeat that. But what they have done is they've put up programs where they've had successes, and written them up in such a way that anybody, whether they're in a community, whether they're in an inpatient setting, whether they're in a CMO, can pick it up and adapt it for their particular local needs. Research-led initiatives, it's probably not my best area to answer on, I'm not going to lie, but I do think it's an area that would be quite interesting for us to be pursuing as we look forward into the future. Yeah.
If I could add, and I don't have an answer to your question in terms of mentoring and availability, but I do think, so I'm working with the National Mental Health Commission at the moment. One of our jobs is around monitoring and accountability. One of those jobs is therefore looking at evaluation of services and the improvements that have been made. And again, I think without being too Pollyanna-ish or optimistic about things, there is a real awareness that we need to be evaluating and critically evaluating systems and services that are in place. But you need the data, you need the systems, and you need the engagement of the workforce. So I'm sure there are resources out there. I don't think I know about them, but I'm sure other people in this room do. And I would really encourage you to keep that interest, because getting service provider and clinician input, as well as service user consumer care input, is what makes evaluation much, much stronger than just the utilisation data.
I think it's a great point. I think what you've raised is a bit of a gap in mental health, which is the mentorship and the leadership training. Most people who are leaders in mental health are people who forgot to step backwards when they asked for volunteers. They're mental health clinicians. They don't have training in management. They don't have training in leadership, and so they just step up out of a esprit de corps. So I think it's a real gap. Jackie's got a hand up, I think, to contribute. Sonia, if you could jog just across the aisle. But that's a great point. It's something certainly we'll be trying to develop equally well, like the leadership, mentorship sort of portal or community of practice. But I'll respond to your other question after Jackie's had a response.
I'm just responding specifically to your question. It's a really good one. In Mind Gardens, we actually have a structured approach to what you're asking, which is called Mind Labs, and it's actually, you're very welcome to reach out to us to help support exactly what you're asking. So the research, the quality improvement on this topic. So we've really built some expertise around that. We're working with people around the state at this point, but it's a national organisation. So please feel free to reach out. That applies to everyone, because actually those first steps and building what you need to develop some quality improvement, even an idea and how to go about that is what we've been doing for the last while. So the team are here. You're welcome to talk to them at the next break. Thank you.
We'll come to you in a sec. We've got a question down the front, and I'll finish responding to this, put an ad in for Ruth. When I was overseas, I came across the leaders of the Bevan Commission, which is, Bevan is the person who's created the NHS in the UK. And this Bevan Commission is actually about identifying leaders and taking them through the process, a one-year process of these sorts of projects, practice improvement projects, and that's all they do. And an interesting, almost today I think, they invited me to come back, they've appropriated our name. They had a session called Equally Well. They said, oh, it'd be lovely if you could come across to that. And I'd love to, but. So this is something we could possibly think about in Australia, a national thing to identify key people, to support them to implement practice improvement. On the other aspect of that, tomorrow we're going to talk about our national scan of initiatives, and that's just not to measure progress, it's also to get a description of the project, whether there's evaluation behind it, and also the contact details of people who are behind that project, so that you can reach out and say, we're thinking of doing this, can you help us? And so we're setting up the website so you can filter that by is it adult or is it children? Is it weight or is it everything? Is it smoking? So you can filter and you go, okay, here's Kat Goodwin in Cessman who've done this, and here's the number, and you can talk to them, here's a description. So we're just, I think, Lee, there's a file in the satchel with links, and I think we're finalising some of the architecture of that, but it is functional at the moment and we will improve it quite a bit. And that's part of that process that might be helpful. There's some, and I don't think you have to evaluate every project. If someone has already done it and the research is there, because it's hard for clinicians to do research, it's quite a whole different additional demand on already overworked clinicians. I think we're struggling for time, so we just need this question and then the last one back here, and then we need to come for final statements. Yes, please.
I'm hearing a lot of
just the microphone up.
Oh, sorry. I'm hearing a lot of talking about the domains of well-being and how we need to address food insecurity or healthy food insecurity and housing insecurity. But something that I've experienced since our disasters and co-occurring pandemics is medication insecurity, and how that affects where we are, especially when we're isolated. And so, for instance, diabetic medications became rather thin on the ground, and there was a lot of flow-on effect to more medications becoming much harder to get hold of. I'm also regional, so I can't pharmacy shop as readily as a lot of people might be able to. So one of the expressions of that insecurity was disordered eating thoughts. And my first place of call was to go to my GP and say, I'm having these thoughts. I'm very troubled by this. I've been here before. I don't want to go back. And he just said, oh, well, just change what you're thinking about. I'm like, so is there any, think a happy thought, is there any way that this sort of insecurity is also being looked at as part of the domains of well-being? Because it's not just diabetic medications. I know that hydrocortisone was hard to get hold of for a while. Targan was hard to get hold of for a while. And, you know, if we're not addressing people's thoughts around food because they can't get the medication they need, or thoughts around, you know, whether or not their adrenals are going to not go into crisis, or their pain is going to go through the roof. These insecurities are very poorly met.
I might ask Ruth to respond to that very briefly, but then also put Professor Amanda Wheeler. We're having a session this afternoon on medication, so I think that's a perfect place to discuss that in more detail with all the medication experts. But we'll get Ruth, if you could just briefly respond, because I'm just conscious of the time, but it's a really important issue and we need to give it more time. Okay, thanks from the college. We'll deal with the question later because of the time, so thanks for that. We've got 3 minutes to sort of do your final statements. So for the people here who are thinking about doing something, somewhere, sometime and when, what would your one piece of advice be in terms of trying to translate the intention into action? So one closing statement for people to take away. What's your term, Catherine? On the bus or on the train or on the plane to have in their minds. So we might go the opposite way this time, and so we might start with you, Kat. The one piece of advice you give people about trying to convert policy into change in practice.
I think people are really happy to share their expertise and experience. So find that person who you see is doing something you want to do and doing it well, and reach out to them, and you'll be surprised they will support and partner, and talk to your local primary health network if you want support to do that and find those people.
But be mindful of the place, the system, the area in which you work. Be opportunistic. You know, if an opportunity arises, grab it and work out who your best friends are going to be and who you're going to need to engage.
Perfect. Thanks, Ruth.
I would probably say be willing to share what's imperfect. Yeah, don't wait for the perfect.
Yeah. And Carolyn?
I think I like to think about evidence-based practice as the policy context, the research evidence, clinical expertise and practitioner expertise, and also the values and circumstances of people with lived experience. So I think, you know, find out kind of what you already have that you can use, and then where the gaps are, and start there. So don't overcomplicate it. I think starting with a conversation, as Catherine said, is a great place to start.
Well, I don't think there's anything more that I can add other than to say thank you to Catherine Goodwin, to Ruth Fine, to Trish O'Riordan and Carolyn White, and can we all join and thank them?